This is Dr. Julie Huffmeyer with our open anesthesia intraoperative TEE case of the month for September 2011. Each month we feature an operative case which teaches or emphasizes an important aspect of basic intraoperative TEE imaging. This month we present a 38-year-old female with a known bicuspid aortic valve and ascending aortic aneurysm who has a chief complaint of worsening fatigue and dyspnea on exertion for the past several months. She also endorses left-sided chest pain with radiation to her left arm. On preoperative evaluation with echocardiography and a cardiac catheterization, her aortic valve area was estimated to be 0.6 centimeters squared, with a mean gradient of 43 millimeters of mercury and a peak gradient of 73 millimeters of mercury, which based on her body surface area gives her the diagnosis of severe aortic stenosis. Her ascending aorta measured just over 4 centimeters in diameter, and her coronary artery anatomy was normal. Bicuspid aortic valve disease is the most common congenital heart defect, with a prevalence estimated from 0.5 to 2%. There is also a male predominance of approximately 3 to 4 cases to every 1 female case. The disease is more complex than simply the bicuspid aortic valve itself. While the pathophysiology of bicuspid aortic valve disease is not completely understood, the disease involves not only the aortic valve, but the aorta and heart from a genetic and developmental perspective. In discussion of a bicuspid aortic valve, it is important to review normal anatomy first. As you can see from this depiction of the valves within the heart, the normal aortic valve, seen here in the middle of the image, has 3 cusps and sits centrally, with fibrous attachments to the mitral and tricuspid valves. It is also directly opposed to the pulmonic valve. Normally, the aortic valve cusps are named according to the coronary artery that originates superior to that cusp, such that the left main coronary artery originates off the left aortic valve cusp, and the right coronary artery originates off the right aortic valve cusp. The non-coronary cusp of the aortic valve is not associated with any coronary artery. A bicuspid aortic valve consists of 2 unequally sized leaflets. The larger leaflet has a central ridge or raphe that results from fusion of the commissures. From this depiction of the heart in short axis with the aortic valve in cross-section, you can see the systolic opening of a bicuspid aortic valve resembles a fish mouth or clamshell-like opening instead of a pie-shaped peeling of a normal tricuspid aortic valve. This same view will be noted on the next TEE clip. The pattern of the bicuspid aortic valve leaflet fusion varies according to which commissures have fused. The most common pattern is fusion of the right and left cusps. This is associated with coarctation of the aorta. Fusion of the right and non-coronary cusps is associated with abnormalities of the cusps themselves. In rare occasions, the cusps are symmetrical without raphe. This TEE clip is the mid-esophageal aortic valve short-axis view found at approximately 30 to 60 degrees multiplane angle. Here it is seen at 45 degrees. This view demonstrates the abnormal bicuspid aortic valve in cross-section, similar to the sketch shown previously. There are 2 aortic valve leaflets seen. Both leaflets appear to be thickened and sclerotic with reduced excursion. The systolic opening of the bicuspid aortic valve appears as a rounded or fish mouth opening. This is the same mid-esophageal aortic valve short-axis view with color flow Doppler placed across the aortic valve. In this view, the color Doppler box is not appropriately placed over the entire circumference of the valve as the echocardiographer has zoomed in and magnified the image such that the aortic valve appears very large. There is no associated aortic insufficiency seen on color flow Doppler of this bicuspid aortic valve. In addition to the valvular changes noted with a bicuspid aortic valve, 50% of adults have other findings as well. Most common is dilation of the thoracic level aorta. While some changes in the thoracic aorta are postulated to be due to flow dynamics or post-aortic valve stenotic dilation of the aorta, Bicuspid aortic valve with thoracic aortic aneurysms are thought to be a result of a single gene defect. There are other structural abnormalities at the cellular level, such as decreased fibrillin, breakdown of elastin, and cellular apoptosis. Decreased fibrillin leads to smooth muscle cell detachment and cell death. Ultimately, these changes in the cellular structure of the aorta lead to aneurysmal changes. Bicuspid aortic valve is found in association with other congenital vascular problems, such as coarctation of the aorta. 50 to 75% of patients who have a coarctation will also have a bicuspid aortic valve. Hypoplastic left heart syndrome is associated with a bicuspid aortic valve as well as other left heart obstructive lesions such as Shone's syndrome with left ventricular inflow-outflow obstruction, Williams syndrome with supravalvular aortic stenosis, and Turner syndrome with coarctation of the aorta. The clinical presentation varies considerably in patients with bicuspid aortic valve disease. It may present in infancy and young childhood with severe aortic valve stenosis or incompetence, or the patient may be asymptomatic for many years and present in advanced age with valve stenosis or thoracic aortic involvement. Most commonly, symptoms develop in adulthood and classically are related to dysfunction of the aortic valve, stenosis or incompetence, aortic aneurysm or dissection, and potentially endocarditis. Shear stress of blood flow across the abnormal bicuspid aortic valve leads to aortic valve calcification, aortic root dilation. Stenosis of the bicuspid aortic valve certainly occurs at an earlier time period than that of senile calcific aortic stenosis, which is seen much later in life, usually in the 6th to 8th decade. As mentioned previously, aortic stenosis is a common complication of bicuspid aortic valve disease. Babies born with bicuspid aortic valve and aortic stenosis can survive, but are at risk for decompensation early in life. The early presentation of aortic stenosis is associated with more severe disease and poor outcomes. When aortic stenosis presents in an adult with bicuspid aortic valve, it is due to leaflet calcification. This calcification is an active inflammatory process involving endothelial dysfunction, calcification, and ossification of the aortic side of the valve leaflets. Folding and creasing of the leaflets and turbulent flow contribute to fibrosis and calcification of the valve. The combination of all these processes leads to accelerated progression of aortic stenosis such that calcification is often present by 40 years of age. In childhood, aortic insufficiency or incompetence develops as a result of redundant prolapsing leaflet cusps, or in cases of endocarditis, or after balloon valvuloplasty. With advancing age, aortic insufficiency may also occur due to dilation of the ascending aorta. Moderate to severe aortic insufficiency is an important clinical predictor for late adverse cardiac events. For patients with bicuspid aortic valve disease, the annulus, sinuses of Valsalva, and proximal ascending aorta are larger than patients who have trileaflet valves, and as such, progressive aortic dilation is more common. Aortic root size is related to valve leaflet morphology and the presence of significant valvular disease, such that in patients with aortic insufficiency, the increased stroke volume may result in stress on the diseased aorta and cause aortic dilation. Aortic dissection is the most feared complication and results in high mortality. Aortic dissection due to bicuspid aortic valve disease mainly occurs in the ascending aorta, with involvement of the descending aorta usually noted in older patients. Risks for dissection include aortic size and stiffness, male gender, family history, and presence of other lesions such as Turner syndrome and coarctation of the aorta. This still image is a mid-esophageal aortic valve long axis view, found at a multiplane angle of 120 degrees. It is most useful for evaluating the aortic valve as well as the ascending aorta. Here you can appreciate the aneurysmal nature of the patient's ascending aorta, measured with the calipers to be just over 4 centimeters. A normal ascending aortic diameter is 2.2 to 4 centimeters depending on the body surface area of the patient. This is the same view as seen before, except in motion this time. This is the mid-esophageal aortic valve long axis view found at a multiplane angle of 120 degrees. The aortic valve is seen in the near field or top of the scanning sector screen. Note that the leaflets are not normal in morphology. They are not the thin, normally delicate leaflets of an aortic valve. Instead, they are thickened and have reduced excursion. Also visible again is the dilated ascending aorta just beyond the sinuses of Valsalva. This is the same mid-esophageal aortic valve long axis view, again with color flow Doppler placed across the aortic valve and the ascending aorta. The color of the blood flow on Doppler changes as it passes through the stenotic aortic valve. You see fairly uniform laminar flow until the blood reaches the stenotic bicuspid aortic valve. Then the flow becomes speckled in colored pattern, an indication of turbulent flow beyond the stenotic valve. The surgical procedure for this patient included an aortic valve replacement with a 21 mm tissue valve and replacement of the ascending aorta with a HemoShield graft. The postoperative TEE images will be seen next. TEE is a very useful technique to evaluate and image the aortic valve and aorta in patients with a bicuspid aortic valve. It is important to evaluate the aortic valve in short axis as well as long axis, both with and without color flow Doppler across the valve, taking note of the mobility and calcification of the leaflet cusps. TE is also helpful for evaluating the degree of aortic stenosis and insufficiency present with a bicuspid aortic valve. This podcast is focused on the bicuspid aortic valve, but future podcasts will focus on the TEE evaluation of isolated aortic stenosis and insufficiency. TEE is also a vital tool to interrogate the ascending aorta for aneurysm and dissection. This is a postoperative image in the operating room after the valve replacement and ascending aortic reconstruction. This is the mid-esophageal aortic valve long axis view, this time closer to 140 degrees multiplane angle. The new valve causes some artifactual shadowing seen as vertical streaks which cause impairment in imaging in the far field. Also visible is the new graft material of the aortic reconstruction. The walls of the aorta now appear bright white, and there is loss of the normal sinotubular junction of a normal native aorta. This is the mid-esophageal aortic valve long axis view with color, done again postoperatively in the operating room. On color after the repair, it is apparent that the blood flows in a more laminar fashion through the new aortic valve and as well beyond the valve into the ascending aorta. There is not as much turbulence in the ascending aorta after the repair. Post-repair, this is the mid-esophageal aortic valve short axis view, this time at nearly 60 degrees multiplane angle. In cross-section, the new valve can be seen. It is tri-leaflet, and each leaflet can be seen to move appropriately in systole. This is a zoomed-in view of the mid-esophageal aortic valve short axis view, with the new leaflets more easily visualized. This is the mid-esophageal aortic valve short axis view with color this time. Again, no aortic insufficiency is noted, which would be seen as turbulent flow in diastole. In summary, the bicuspid aortic valve disease is the most common congenital heart defect. The aortic valve is abnormal in that it has two cusps and it is subject to stresses that cause development of early aortic stenosis. Aortic insufficiency may also develop due to the bicuspid aortic valve as well as dilation of the aorta. Other non-valvular findings include thoracic aortic dilation and dissection. TEE demonstrates the changes associated with bicuspid aortic valve and can help with therapeutic decision-making and guide surgical repair.